Just a quick audio check. Quick audio check. Can you guys hear me okay?
Yes, we can hear you in neurotrauma.
Awesome. Thank you. All right, everyone. Just a final check. Can you guys hear me okay?
Yes, sir.
Yes, we
All
can.
right. Awesome. So let's get started. My name is Jacob Mathew. I'm one of the faculty attendings for the internal medicine residency program. It's honestly my distinct honor and pleasure to be able to talk to you guys for grand rounds today. As most of the residents who have gotten a presentation from me know that rarely do I finish on time, but I will finish on time because it's a grand rounds. I have about 100 plus slides. So I'm going to be sending these out just so you guys have more information. I'm not going to clearly go through all of them, but I tried to make a very thorough presentation, and I utilized some assistance from COPIC, which is our malpractice insurer, as well as some information from Colorado Medical Society. So just to begin, I'm going to be using a polling feature through Zoom. You don't need any software. You'll see it on either your computer or your phone, however you're watching or listening to this. None of these responses are recorded. It's purely just for educational purposes, just so we can kind of see how we all feel within the institution and compare that to how some of the data has panned out, from a state level as well as a national level. I want to make sure I give a thanks to Dr. Lembitz and Zacharias. Dr. Lembitz is our legal counsel here in the hospital who reviewed this PowerPoint to make sure everything looks okay, as well as Dr. Zacharias at the CMS Colorado level. So we're going to go over 4 major areas. I'm going to start with really the basics of law. Most of us are not lawyers. So I just want to go over some of the understandings that predate what led to malpractice and what it's become today, so we understand kind of what we're getting into just as physicians. And I'm going to go over some legal statistics. These are kind of hard to really get because a lot of it is hard to find from a public standpoint. So I have some good data from the National Practitioner Data Bank that I think a lot of you might be surprised at in a good way, kind of good and bad. We'll talk about it later. Some real world cases. None of the cases discussed are from Parkview Medical Center or even Colorado for that matter. But these are all published cases, as well as some resources available, which I think is the most important thing. For any PowerPoint or any presentation or lecture you go to, in reality, there's only going to be maybe 2 or 3 things you get out of it. So I understand that. And I would say that of all the things that we're going to talk about, the things that I want you to understand are really the statistics that are happening from a medical legal standpoint and the trend that they're heading towards, and some of the areas specifically by specialty that are higher risk from a medical legal standpoint. And then the resources that are available to us here in Colorado through COPIC that can assist, decreasing our chance for ultimate litigation. So let's go through the basics of law. It really comes down to 2 things, whether it's criminal law or civil. Criminal is what we see most of the time on TV, whereas I would say TV meaning like CNN, Fox News, any like major news outlet, whereas the civil law is what you kind of see with Judge Judy, Judge Joe Brown, whichever you want to call it. I'm more of a Judge Judy fan myself. Criminal leads to crime. So as a result, or dealing with crime, so the severity of the punishment, because it's a crime or because it's a loss of freedom, changes the outcome of how it has to be determined, meaning you have to be beyond a reasonable doubt, as we've seen in court cases, because of that severity, meaning that someone's going to lose their freedom. Whereas civil is different. This is between individuals. It's usually some kind of small dispute, small claims court, et cetera, car accidents, what have you. And because the outcome is not as severe, meaning most people will only lose money, not really their freedom, it changes, and it's more likely than not. So greater than 50% likelihood. These are not really cases where they're handled in front of a jury. These are in front of a judge. So when we think of malpractice, for the most part, it's going to be civil cases, so that more likely than not. And that's going to be important when it comes to your defense and the plaintiff that's representing the patient in regards to how they're going to tailor their case. So what is malpractice? There's multiple ways of defining it. I'm going to have you pay attention to the last bullet, which is, there's a violation of a standard of care that led to an injury that was secondary specifically to this violation. And that injury led to some damage, resulting in that patient hoping to get some reimbursements that often are in a monetary format. But when we look at that term negligence, that's really where the key comes down to, because it has a very specific meaning. There's 2 different types of error that seem to occur, but the main one that a lot of us worry about as physicians is clearly human error. But when it comes to human error, there's hopefully, no intent to actually do harm, But when it comes to negligence, while you still had no intent to do harm, your care fell below what is expected of someone at your skill level within your field. So this is really important because I'm going to be talking later about the risks that occur as we work as attending physicians for those of us that are listening that are attendings, working with residents, fellows, et cetera, because a lot of the residents are still going to be held to a standard of internal medicine. It's a fellow, cardiology, GI, pump, crit, et cetera. Not necessarily someone at their level of their training because they're still practicing under your degree. Whereas again, human error is purely just going to be just inadvertently, again, doing something, but it should not have been done. Again, negligence is going to be that there was some harm that resulted from that because a standard was not met. These last four areas are going to be the most important or the last four elements I'm going to talk about in a second are really important to know because all four must be met under that more likely than not clause that I talked about on that previous slide. So these are the four elements that when there's a case that's going to occur that needs to be met before malpractice can be considered to have occurred. First, that there's an established duty of care. That I'm going to talk about all these in a second. This is kind of the legal way of describing all these, and I'm going to try and translate it to something that I think most of us that are not lawyers can understand. There's a breach of that duty that's been established leading to an injury, and that injury led to actual harm to the patient. So let's kind of translate each one of these. First, that duty is, or the care has been established. So there's a relationship. In most instances, this is implied, especially in the hospital setting. When we're consulted or we accept a patient from the ER for a transfer, they are clearly under our care. The times that this can lead to a gray zone is when you're potentially in an airplane and there's a medical issue that arises and someone asks, is there a doctor on board? And all of us kind of look around and hope someone else is going to raise their arm first. I just want to remind you, if you're not muted, please mute yourself. Okay. And then second, the other times that can happen, from a wilderness medicine standpoint, if we're, taking care of someone, if we're maybe on a hike or doing something on the outside and we come across someone who's injured, that's this time where you could potentially establish, a relationship between you as the provider, as the patient, or even like car accidents, for example. The next thing is that once that care has been established and you render care to the patient, it falls below a standard, again, that's expected by a practitioner in your field. This is really the most important element that we commonly see, on TV, where there's an expert witness that comes in. And why do they come in? They're coming in to be able to establish whether whatever was done, whether it's a diagnosis, treatment, et cetera, was that something that would have been done, or whatever the descriptive case is, by someone else in that field of that expertise. So when you have that established relationship, you've provided care that unfortunately fell below the standard, then there's usually an injury that has to result for this to, again, even start moving towards the potential for malpractice occurring. And once that injury occurs, there's some damage from that injury, whether it's prolonged hospitalization, permanent mobility issues, neuropathy, et cetera. These are what the plaintiffs that are representing the patients, that's what they're really looking at, is to see, okay, based on that damage that's occurred, how do we decide what's the monetary amount that should be requested? So now that we know from a medical legal standpoint some of the basics of law, let's go into some statistics and some information about how long the medical legal realm has kind of existed. It actually can date back really far back to 2030 BC. I'm going to read this quote out, but what it came down to was they found that, when a doctor is treating someone, if you had led to them dying, or your treatment led to the patient dying, or maybe it led to them losing their eyesight, it wasn't an eye for an eye, it was actually an eye for a hand. They would actually cut off your hands. So luckily we've progressed beyond this type of punishment now, to the point where it's, monetary, not really physical. But, we see that going now to, let's jump from 2030 BC to the 1800s. The 1800s is truly when first malpractice cases existed in the United States. And then in the 1960s, we started seeing more cases start becoming frequent. And since the 1960s, more recently, while there has been an increase in cases, what I'll actually say, and one of the good things that I told you early on about learning or remembering some of the important points of this presentation, one of which I said was hopefully understanding the trend that we've headed to. We've seen an actual decrease, specifically here in Colorado, of malpractice cases, but an increase in the severity of those payouts. So let's go over some statistics. About 35% of claims are due to a diagnostic error. Not that many are due to surgical complications. I'd say that we're getting a lot better overall as a medical community, with the decreased risk for surgical complications. And I think a lot of this has to do with the use of checklists. For most of you, if you're not a surgeon, or if you remember rotating as a medical student as a surgeon or with a surgeon, you remember that there's a timeout, there's clear checklists that they typically have on a board or on a computer screen, whether it's how many tools are being used, gauze, et cetera, to make sure they don't leave any of the patient, et cetera. And these checklists really came from the airline industry. I spent some time working in the aviation industry, and those checklists are vital. Those are what allow us to make sure that everyone's on the same page and that we're not just assuming things are happening, but we're documenting that something was done or wasn't done. The fourth bullet point I thought was quite interesting, because we see that 43% of patients that ended up filing for malpractice were actually inpatient at the time. And why I thought that was interesting is I thought that personally inpatient would have been a higher risk, but we're actually seeing the majority of the patients that lead to malpractice cases are outpatient at the time. Most are in the 50s to 60s, but I'll give you some data. This is for Colorado, but I'll give you some data to show that overall in the United States, it kind of seems to range more in the 70s or so. And again, focusing on Colorado specifically, there has been a 46% increase in the actual payouts as well as the amount that's paid out, which seems to be around $363,000 per incident. But again, the overall claim amount or the number of claims has decreased. Looking at the slide to the right, we'll see that, I'm sorry, I'm just going to move the chat box over here. So we can see that the overall number of claims has decreased overall. Again, there's a difference between MDDO as well as overall claims. So we're factoring, dental, chiropractics, all of our other allied health professionals. But when you adjust it for inflation, it's actually decreased. So this is overall in the United States. But again, this is only going down to about 2017. If you weren't to adjust for inflation, there's clearly going to be an increase, but that wouldn't be a reliable statistic. Starter did some studies back in the New England Journal of Medicine, and they reviewed the National Practitioner Data Bank, which all of us know about. All of us are part of that. And if you don't know, the National Practitioner Data Bank is where a majority of the information on physicians and providers is kept as a overall database, whether it's malpractice cases, if you've been, different hospitals you've worked at, et cetera. And when they looked at over 408,000 physicians, they found, this is really interesting, 89% had no claims at all. But if you looked at those that had a claim, it was less than 10%. And then within that 10%, only 2.3% had multiple claims, 2 or more. But these accounted for 39% overall of all the claims in the United States. So while we might see that trend previously where maybe it was staying stable or increase or decrease in terms of the frequency, if there's a trend that we ever find statistics wise overall for malpractice where they're showing an increase, I would argue that it's not because there's more physicians that are being involved in. Instead, the data that I found suggests that instead it's the same physicians, unfortunately, that are being involved in legal cases. If you look at 2016 specifically, 1% of physicians accounted for 33%. So you can look between that 39 to 33%. 33% were accounted by 1% of physicians. Those that were, polled anonymously found that after they were sued, even just one time, they were more likely to shift into a small practice, or even, to the extreme, stop practicing medicine or go to a smaller hospital. Maybe they're going to potentially, shift from an inpatient or an outpatient to an inpatient setting, again, because, we're seeing that statistically the cases of malpractice are higher in those that are in the outpatient setting. So let's go to some more statistics. How often do they actually occur? Again, this is hard to truly find because a lot of this data is not public. It's a lot of the cases too are handled privately, so you might not have some of the most accurate data depending on who you're researching. But we see that 1% of all hospitalized patients, so again, about 43 or so % of patients that underwent malpractice claims were on the inpatient setting, and of that 1% actually suffered an injury significant enough that led to, or or led to an injury, and then 2% of that 1% actually initiated a claim. So again, percentages of percentages, but in the end, it's not that large of a percentage of our population that we're dealing with. Most of these, more than 60%, actually were dismissed because, again, you have to meet all 4 of those criteria that we talked about. And if any 4 of those are not met, then the case is going to be dismissed. So, and then 1% of the 60% that ended up being filed did lead to some kind of litigation, but I don't have further data about what ended up with that litigation, whether it was, again, ultimately dismissed or if there was a monetary payout that resulted. So I'm going to get to this, how many leads to deaths, in a second. But if we look again at these adverse events for medical treatment, that's what the AEMT stands for. Leading up to 2014, this is from the JAMA. We found that from 1980 to 2014, the overall trajectory seems to be somewhat stable, maybe somewhat increased overall. If we focus on the orange area, which is the surgical and perioperative adverse events, I would argue to say that based on this overall look, it appears to be somewhat stable. We've seen that adverse drug events, which is dark blue, seems to unfortunately be increasing. I say unfortunately because we hope that with the advent and implementation of electronic health records, that this would help decrease the amount of adverse events. But the other thing to consider is with the progression of medicine in general, that we have more and more medications that are available to us, whether they're chemotherapeutics, or other pharmacologics in a cardiac, GI standpoint, et cetera, et cetera. And some of these on their own have higher and higher risks regards to side effect profile. And with the explosion of the number of medications that are available to us, we know that it's harder and harder for us to keep up with a lot of these too. So as a result, you can argue that might likely contribute as well. But again, this only goes to 2014. So maybe from 2014 to 2020 now, you might see that with EMR starting to get more and more sophisticated, hopefully we'll start seeing this stabilize, if not decrease. So let's look at how many actually led to deaths. Well, between 1990 and 2016, there was an actual decrease in the national age standard mortality rate relating to medical treatment. What does that fancy text mean? It just means that since about 1990, we've seen less patients actually die from the injuries occurred secondary to malpractice. And if we look at Colorado specifically, the darker the color, the better, because that represents a decrease in mortality. And we can see in Colorado, we've had between a 32 to 47% decrease in mortality during that same range that I mentioned on the previous slide. California, I'll bring your attention to, because overall we've seen that of the states that have since 1960 higher cases of malpractice frequency, California is one of them, as well as New York and Florida. So both New York and California have since seen a decrease in the mortality of patients that were hospitalized secondary to an adverse medical treatment or during the hospitalization had an adverse treatment. Whereas Florida, which is one of those states also that has been seen since 1960 of having higher percentages, they haven't had as much of a decrease. Again, focusing on Colorado, but this is showing the overall claims for all states per 1 million people. I mentioned on the previous slide that New York was one of the leading states for the number of claims, as well as California down here. But what we saw from 2012 to 2016 in general was that the frequency, again, of the claims is decreasing, but the severity is increasing. So again, one of the statistics I really want you to take out of this is it's not the number of claims that are going up, but it's rather the severity of these claims as well as the amount paid out. So while patients aren't necessarily dying, there's unfortunately a higher morbidity occurring secondary to these events that's leading to these higher payouts. The other trend that we're seeing, and this was from Dr. Liebitz that mentioned this to me, was that now in general, we're seeing that plaintiffs, when they are suing physicians, it's not just that one physician that's involved, but they will review the entire chart, and any name that's on that chart, they pretty much will do a blanket lawsuit for all names. And then it's up to you if you're on that, even though if you had nothing to do with what led to the ultimate, malpractice injury, it's up to you to kind of defend yourself as to why you were not involved, as well as co-naming the hospital. So it's not just the physicians, but it's the hospitals they worked at. I wanted to put this in because we know here in Colorado, specifically here in Pueblo, we have a larger Hispanic population, and we can see that in general, we would assume that any patient who speaks a language other than English as their primary language, or if they don't feel comfortable speaking English fluently, and from a medical legal standpoint, that can clearly increase your risk potentially. So I wanted to find some data. I wasn't able to find large numbers, but we found that if you looked at the 2017 census first, let's kind of look at that. We see that 11.9% of patients in Colorado, or people in Colorado, felt that or said that Spanish was their primary language that was spoken at home. This is very close to the U.S. average, whereas Chinese, German, Vietnamese are a little lower percentages. But again, this is to kind of show you that we do have a larger Spanish population, and as a result of that, we have to be cognizant of making sure that we're able to translate information to them in an appropriate way. Not only is it hard for us in general as providers to somewhat translate medicine from what we understand to any terms or language that any patient would understand, but when you add the language barrier, that adds another element to consider. So when they looked at California, and this was the only data I could find specifically regarding malpractice cases, but when they looked at California, of the 35 claims that were filed, 32 of the claims, and these are claims that were related to some kind of language barrier that was listed, 32 did not use a competent interpreter. And this was to suggest 12 were family members, 2 were minor children. So why do I bring this up? Because we have devices here in the hospital that are purchased for us to use that are available on every floor to utilize when we have a patient who does not speak English comfortably, that we can integrate into our medical care. But sometimes we might not use that because whether it's a time restraint, it takes time to load up. But I would argue that if you feel that utilizing a family member, whether it's a spouse, a child, et cetera, even if they're not a minor, that is not a surrogate, an appropriate surrogate for using a translation service. So I would still argue, make sure you're using those. Most of the time, I've had multiple patients on 5-Tower where this has been the case, where we're able to keep that interpretation service device iPad in the room to kind of decrease the amount of time that it might take to get it set up. And usually it's within a minute at most, I've been able to get them loaded up. They will give you their identification number if you haven't used it before. And so I recommend that after you use the service and then you document your note, put that information in your note. So then it's very clear later on, if it needs to be reviewed, that there's documentation that you utilize the service. Okay. So we've talked about language, but what are some other areas where malpractice claims are higher risk, where there's a lot, right? So I'm going to go through each one of these individually. So from a neurologic standpoint, strokes, hemorrhages, things that obviously increase high or lead to morbidity are going to be more common. But because of the severity of a missed or delayed diagnosis when it comes to the brain in general, that's why this failure to or delay in diagnosis was so high when it came to the neurology field versus infectious disease or cardiology. If you look at GI, to include emergency medicine, perforated organs, ischemic bowels, things that are going to likely lead to very severe surgical procedures that are going to need to be done, and obviously high risk for morbidity because some of these patients may need to have a colostomy for the rest of their life. So when you look at the conditions that are going to increase or have a higher risk for someone having long-term ramifications from that, you can assume and imagine that that's what's going to lead to higher risk for malpractice. From a cardiology perspective, as well as, again, emergency medicine and chest pain, we all know that most commonly the times that we see, especially in the outpatient setting, someone coming in for chest pain is when they come in for something completely different. And then right as you put your hand on the doorknob, that's when they say, oh, by the way, and then they mention chest pain. It just happened last week when we were staffing at the clinic. So these are the ones that you just have to be aware of. Utilizing scoring systems like the heart score in the emergency room, your TIMI Grace, depending on if it's unstable angina and STEMI, utilizing those to decide, from a management perspective. And the nice thing here, Parkview, we have so many subspecialists and services available to assist us with the care to make sure that we're approaching these in the right manner. Infectious disease, things again that are going to lead to high morbidity. So deep space infections or neck fascia that are potentially going to lead to very severe surgical procedures need to be done, septic joints, which could eventually lead to, again, higher morbidity or even a loss of that joint, and then encephalitis and meningitis that could, I think from a long-term perspective, some of these patients might not recover completely. Oncology, it would not be surprising that some of the top 3 cancers or so that are seen from a statistic standpoint are going to be the ones that are more commonly listed in their field for malpractice. And the procedures, we mentioned this with surgery, saying that overall we've seen this undulating pattern, not somewhat of an increase in pattern or frequency, but I'd argue that if we look far back, there's probably been a decrease in the frequency of surgical outcome or adverse outcomes because these use, again, of checklists and timeouts. And then the informed consent is so important. All of us do procedures, whether it's internal medicine or the subspecialties and fellows. And then informed consent is imperative. We have multiple ways of doing it, whether it's the online system here in the hospital, paper. I would behoove you or urge you to say, or to do that if you use a paper to ensure that that really does get into the chart if you're not using an electronic form. And then again, making sure you get that timeout performed. So we've talked about some of the basics of law about 26 minutes in. We've talked about some of the statistics, both in Colorado as well as the United States, and then some of the conditions that are high risk for malpractice. But the question really will come down to is why are these errors even occurring? And there's 2 types of errors that we need to really delve into is human error and systematic or systems error. Human error and systems error went head to head in this landmark trial paper, I should say, in 1999 that came out, and it was called To Err is Human. Anytime you do research when it comes to medical legal malpractice, you're going to find this come up every time. And the reason why is because it represented a paradigm shift in how we approached malpractice and how we cases and how we sought to improve the medical field in general. And it was because they found that most medical errors were unavoidable human error. So if we saw that a lot of these were unavoidable, well, then how are we supposed to improve? How are we supposed to ensure that patients are going to come into the hospital and feel comfortable that there's not going to be an error or something that happens that's going to lead to adverse outcomes? What they found was that the reduction can occur though through systematic changes. So if there's a lot of errors that are potentially due to human error that we cannot fix because humans are humans and humans will make errors, what if we decrease the amount of systematic error or the risk for systematic error that's occurring so we can limit any errors that do occur to being just those ones that unfortunately we just cannot, it's going to be harder for us to truly decrease. And we felt that overall in this paper that punishing for these errors led to workers just hiding that the errors even occurred. They just didn't want to report these errors. And that is what led to this QI movement. Dr. Vijan is our quality control, chief quality control officer. And what, if any of you that have worked with him, have presentations from him and have done QI projects, there's been a huge push here in the hospital for decreasing any barriers towards initiating QI projects. And this is where the QI movement really started, because they felt that while there's human errors that are existing, there is also systematic errors that are also present or coexistent. And if we can target those systematic errors and decrease those as low as possible, then whatever errors that do occur are ones that were not truly negligent, but were ones that we just could not control because of the fact that we're humans. So I will focus your attention to this quote in the middle right of the screen. It says, "Every system is perfectly designed to get the results it gets." What does this mean? What it means is that if you have a system that is designed to consistently lead to errors, meaning it's making it hard for orders to go in, it's not appropriately doing medication checks for interactions or allergies, et cetera. There's only so much you're going to be able to do because that system, the computers are only as smart as the people who design them, and it's going to consistently provide that or lead to that error. So we have to revamp our system to make sure that it is constantly being ratified and evaluated so that we are getting the most optimal outcomes. And if you look at this, the blue text, what I said is, there's 2 different things that we have. We have a legal system and then the system safeguards of the QI. The legal system will kind of focus on our negligent errors that are not necessarily due to the system, but due to humans or providers performing an error that was well beyond what was expected for someone in their field. Whereas the system safeguards, the QI, is there to identify those systematic errors and how we can fix them. And knowing that there's the human error and then the systematic error with the QI projects or QI systems, it's important to understand that this is not unique to just medicine itself. These type of things are occurring in every field. And medicine, though, is unique. And I think the reason why part of it's unique is two major things. First is this blame and shame mentality. We have a culture of silence. Sometimes we feel ashamed if we've been potentially named in a legal lawsuit, whether or not we were at fault, because we like to be perfect, right? That's most of us are type A. That's how we got to where we are. And being able to admit that we're not perfect is one of the most important things that I think all of us can do as human beings towards not only decreasing our stress, but improving our own well-being. And then there's the systematic constraints, whether it's increased or decreased, I should say, staffing, the myriad of knowledge that's required. I mentioned that with medications. I know I get about 4 or 5 emails on a daily basis on new articles that are coming out. Trying to just keep up with this can be very overwhelming. And we all know about the high risk for burnout that exists, especially in our profession, especially with this pandemic. And then communication. We have so many different providers, whether it's nursing staff, physicians, ancillary staff, case management, et cetera. They're all trying to work together, but at the same time, we're kind of separated because we're not as a team. We've seen that team like mentality that is highly utilized in the ICU setting has proven to be beneficial, but it's easier to say that that's helpful, but it's not as easy to implement it when you have, again, decreased staffing. So I'm going to focus some time more on this communication aspect, because when we look at it, communication is really what it comes down to. And is it important? Well, it clearly is, because when we look at what patients want, and this is some data from 2003, what we found is that patients expect, and I think all of us would agree to this, that when an error occurs, that they're going to be told. Admitting an error and apologizing is important because it not only does it show respect that you have for that patient, but it shows this important area that I want you to focus your attention on, this mutual sense of suffering, that you're hurt also, that not that you're upset in yourself, but you're upset that it even occurred. And that initial apology is what's going to help facilitate some type of healing with that first of the 4 elements, that patient-doctor relationship. If we look specifically at data, because we all know for these first 2 bullet points, it's more anecdotal, like it's very clear that these would improve things. Patients want to know, we know that. But let's look at specific data of those patients who had an error or something occur to them, whether it was during a hospitalization or in the outpatient setting. Of those who were told, only half were explained what happened. What does that mean? Well, they said that an error occurred, but they didn't even know why that error occurred. And only a third of them actually recalled receiving an apology. So I think this is important because it's simple things, us as humans treating other humans as we would like to be treated ourselves, right? And it's important to make sure you have all 3 of these elements. The first is just saying that an error has occurred. The second is to explain how that error occurred without, putting people under the bus. We're trying to put the blame game. We're just saying this is how it occurred, and then apologizing for that error, and then finally explaining how you're going to fix it. Most patients want to ensure that the error is not going to occur again. And sometimes I'm going to show you some data that we're seeing that a lot of times that patients feel the need to sue. It's because they want to make sure that someone is held accountable and to prove that this is not going to happen again. And they feel that the only way to prove that it's not going to happen to someone else is by pursuing legal action. So why are we poor at telling patients about these errors, as I showed you some statistics? Well, again, going back to what I just mentioned in the previous slide, sometimes it feels like we're challenging our pride. We swore to do no harm, but in the end, we did harm. Again, in most instances, it's not intentional. And then we wonder, is the patient ever going to forgive us? Are we going to have a permanent loss of that patient-physician relationship? But what if we don't have a diagnosis? What if we know that an error's occurred, but we don't even know, or maybe we're seeing a patient and we just don't know what their condition is from? I think it's important for us to all accept and be able to tell patients that sometimes we just don't know, right? I think the field that probably sees this a lot potentially is the emergency medicine field, because they have such a short amount of time to work up a patient. And in that short period of time, they have to figure out very quickly, is this someone that needs further monitoring or not? And there are times where we do an advanced workup, even in the inpatient setting. And despite our labs that we're ordering, the imaging, et cetera, which I'm going to get to in terms of the benefits and cons of doing that approach, whether it's because we're trying to work something up or maybe it's more defensive and we're trying to make sure we don't miss something. Sometimes we don't end up finding the diagnosis, and that's okay. And I think as long as you tell the patient, and I've said that multiple times to patients, and I don't recall a single time where a patient was upset. I told them, I know that it's not this, and I'll tell them the major conditions I want to rule out, but I don't know what it is, but I do think it's safe if it's on the inpatient setting. It's safe for you to be followed up as an outpatient, et cetera. Of the things that we can do though, other than just not only admitting an error's happened, apologizing and being honest, whether it's a diagnosis that we don't know it exists, it's sitting down. Most of the residents that rotate with me will know if they've seen a patient after I've already been in the room, because they'll usually see a chair that's pulled up next to the patient's bedside. And it's because I found that it's just easier to sit down next to the patient and be at eye level. If any of you have been in a hospital or in the emergency room setting, you know that it's very daunting when you have someone that's standing over you and talking. And that relationship and communication can, I think, be facilitated in a better respect if you're at the eye level of that person. And sitting down is a very powerful body language to consider. So that a crucial point, though, not only is just sitting, but it's that first greeting. So are you showing concern? That I put this handshake in here, but when I initially developed this PowerPoint, this was before COVID kind of came out. So we're not doing the handshakes anymore. But there'll be times where I'll just do a little elbow bump to the patient. Are we smiling? Well, maybe we don't have to because we have a mask on, but if we do eventually get away from using masks, those are important things to be considering, is your overall demeanor when you come in. Explaining what the purpose of the visit is. I always explaining who you are, every time you come in, because sometimes we don't realize how many physicians or providers these patients are seeing, and it can be so overwhelming to them. And just maintaining eye contact and not staring off or looking at notes, etc. And not just sitting down and maintaining eye contact and having a warm overall physical appearance, whether it's smiling, etc., but it's even the vocals, the way that you're talking. So we found that in a study, a physician's voice was a predictor of whether a patient, there's a question, I should say, is a physician's voice a predictor of whether he or she has been sued? I thought this was a very interesting study that was back in 2002, where they found that they played audio clips between physicians or surgeons and the patients, and they had other people listen to those audio clips. And they found that within 40 seconds of hearing an audio clip of a surgeon's visit specifically, they were able to accurately correlate whether someone had malpractice history in their past. So what does that mean? They found surgeons that had been sued in the past. Those had not been sued in the past. They, randomly mixed up these audio clips, and they had patients or providers or people in general listen to these clips. And what they found was within 40 seconds, they were able to say, yeah, based on what I'm hearing, not even seeing them, just hearing their tone of voice, maybe how fast they were talking, maybe they were talking more than they were allowing the patient to talk. They were able to appropriately, or not appropriately, but accurately reflect whether or not that patient probably, or the provider had some kind of malpractice history. Levinson did a similar study back in 1997, and they utilized recordings from over 1,200 visits in the outpatient setting by primary care physicians, and they found very similar findings. This was both in Oregon and in Colorado. So I thought that was very interesting. Sometimes we don't realize how our voice comes off to others, right? And what is the type of voice, if we were to learn something from this, that seems to be perceived more from a positive standpoint? Well, it's not just the voice that uses humor and laughing. Again, my residents will know that I try and incorporate some kind of humor, whether how negative the situation might be perceived. I always try and leave the patient happier than when I came in. Something that's showing some empathy and caring, and not just the tone of the voice, but it's how long you're talking to them. So we know that in an ideal world, we would all spend a lot of time in our patients' rooms. We know that's not always possible, but just a 3-minute difference, those that spent more time, 18 minutes versus 15 minutes, are more likely to be perceived in a positive retrospect. And then asking for patients' opinion. So I always do this to patients the first day if they're admitted. I say, so what brought you in? Because I want to know if they know what's going on, et cetera, right? And it ensures that you have this team-like atmosphere, that you're working together. So again, patient empathy, this bottom bullet, is one of the strongest predictors of patient forgiveness. So if you are showing empathy or you're portraying this image of empathy, you're less likely, statistically, that I've seen, to be sued by that patient. But we know that not all patients are some of the most fun to deal with. We have our angry patients, and it's usually our tendency naturally to just defend ourselves when we have someone who is angry at us, and we take it personally. But it's important, sometimes easier said than done, to step back and realize, try and find out where they're coming from. So when I have a patient who's angry, I just say, so tell me, what is upsetting you? Because maybe we think we know what's upsetting them, but it's something completely different. Maybe it's the type of diet they're on. Maybe it's that their TV's not working, they can't get their volume to work. So there's a lot of things that can really upset patients. Maybe it's the person they're roomed with. They're making a lot of noise and they can't get any sleep. And because they're not able to get sleep, they're just really cranky. So there's things that we can do as physicians, and we can work with our nursing staff to try and help those. But it's important to make sure that we don't initially try to take it as a personal attack or be on the defensive side. And then just very quickly, I included this just because we're seeing more of telemedicine, obviously with the pandemic going on. So they found that when they looked at a study of 551 cases, just in about a 1 or 2 month time period, in 2018, they found that no cases actually led to litigation against a telemedicine physician. Now, does it mean that telemedicine is practicing a higher standard of care than we are? I would say no. What likely is occurring is, first, telemedicine is very good at enacting medical legal terms, meaning in the very beginning of the encounter, they're saying if patients know that there are certain things that we can and cannot do, and not all cases are reviewed from a telemedicine perspective. Usually narcotics are not even dispensed through telemedicine visits. So you're able to focus your attention on specific areas of care, which maybe will not lend themselves to high risk or medical legal, as I talked about on that one side with all the different areas of medicine. So should we say sorry? Now, I think when a lot of us think of medical malpractice, we not only think about the statistics, so I have about 20 minutes left, so I should be on time, but we think about the statistics that are going on. Again, we're not seeing increased cases, we're seeing increased payouts, but we're seeing decreased frequency. We know that we should sit down, talk to the patient, try and have an empathetic voice, make sure that we're working as a team, making sure that we admit when an error has occurred. But when that error has occurred, should we say sorry? Does that increase our risk for liability? Well, why would you, first of all, approach this topic of saying sorry and talking to them on error? It's, again, patients want it and they expect it. And again, it maintains that relationship and it reduces that likelihood of a lawsuit. Patients, we know this, patients, just as ourselves, as we're patients too, want someone who's honest, concerned, empathetic. We want to know, and they want to know why something happened, what's going to be done about it, and that you'll stick with them throughout the entire process. Just saying sorry alone is not going to work. So it's saying, I'm sorry that this happened. This is what I'm going to do about it. This is what we're going to do as a hospital to make sure this doesn't happen again. And I'm going to be with you, whether it's in the inpatient or on the outpatient setting. One of the nice aspects for our program is that we have outpatient clinic. So if we have a patient that we have seen in the hospital who happens to be a patient in our clinic, we're able to either delineate or create a telephone encounter for our provider, or we can ourselves see them as an outpatient. So making sure they don't feel left out or left out to dry is important for them, knowing that they're going to not be left alone, right? But I think that most of us as providers ultimately will fear that if we say we're sorry, it's going to increase our risk, right? Because we're admitting fault. We said sorry, so clearly we are acknowledging that something bad happened, and we're only saying sorry because we felt bad because we did something. But that's actually not the case. What we're seeing is advocates for saying sorry have found that it actually decreases your malpractice risk. So this study back in the Annals of Internal Medicine, 1990, found that in the VA hospital setting, those that said sorry are more likely to not actually have a legal case brought against them. And others have found similar, not just in the VA setting, but this is nationwide. It's led to decreased number of lawsuits and a decreased amount of money that's ultimately been requested if a lawsuit does ultimately happen, with a faster resolution. So this is important. Again, saying sorry does not lead to you admitting fault. It's instead going to help branch and bring together maybe what seemed to be a fractured patient-physician relationship and lead to quicker healing. Those physicians who have poor relationships with their patients are the ones who typically get sued, right? So if you're not talking to your patient enough, not taking the time to admit that an error happened, et cetera, those are the ones that are really going to be at high risk. And the legal considerations is when you're going to say sorry and you're going to apologize, it's just keep it simple. It's saying that it shouldn't include statements. Again, I mentioned this earlier, when you're saying, okay, I'm sorry something happened, this is what happened, and you're explaining it. Don't bring in other services, even if they were at fault, right? I would say that it's up to them to also come and see the patient on their own, but we should not say, well, this service did this, that's what happened, that's why you had what happened to you. We're all a team, we all work for the same hospital, and we're all here for the same purpose, which is to take care of that patient. So we should make sure that as a result, if there's any legal situation that potentially can come forth, that we're taking it from a team perspective as well. And of everything on the slide that I want you to focus in on is this very last bullet. Provide that apology early and when you first observe it. If something happens and you wait days and days and then you apologize, I think that time that has expanded from that period of when it first occurred to when you decided to say sorry is likely going to just make it harder and harder for you to recoup that relationship and the breaking of the relationship that's occurred. The Colorado Candor Act was something that I did not know existed, and I think it is an awesome law that all of us should know about. And it's very similar to our federal law that came about in 2005. And what it says is post-event discussions between doctors and patients and their families are inadmissible as evidence in a malpractice lawsuit as long as certain elements are met. And I'm not going to talk about those specifically, but what it's really saying is when you know that an adverse event has happened and you go and talk to that patient, that family, from that point on, as long as you are not claiming fault by a certain provider, a certain service, or et cetera, and just saying sorry and explaining what you want to do to make things better, that cannot be used against you. They cannot go to court and say, well, this physician said they were sorry, so they clearly are admitting fault. That is not how it works. So not only in Colorado, but even at this national level with the National Medical Error Disclosure and Compensation Act, if you say sorry, it cannot be used against you. And furthermore, we've seen that with disclosure programs, which I'm going to talk about through COPIC, which is a 3Rs program, it actually hinders ultimate reporting to the National Practitioner Data Bank, right? Because when some of these reports go to the NPDB, those are for life. That's for the entire career. So by saying you're sorry, it's actually leading to less outcome or cases that lead to litigation and then less reporting. I would say that when you go in to say sorry, I put this bullet saying always have a second team member present. If that team member was not involved in that person's care, then I probably would not recommend having them involved in the discussion. But if they were, whether it's an attending and a resident, or one attending and another specialist, those are helpful to have because maybe, just like a family meeting, making sure everyone that was involved is able to answer questions is important because the patients want to make sure that all their questions are answered and they know what's going to be done about it. And I just put that there's other states that have a similar Candor Act, but again, the Medic Act of 2005 has covered us from a national perspective. So now let's see if I can get this to work. So it's the poll time. So would you say that you practice defensive medicine? So you should see it pop up on your phone or on your computer screen, hopefully. So I'll do this for about 20 seconds. We have about 5 seconds left. All right. So let me see if I can share these results with you. So you can say 54% of you all said, yes, you practice defensive medicine, 21% no, 25% were unsure. So should we practice defensive medicine? So there we go, stop sharing. So that's really the ultimate question, right? What is defensive medicine? Well, it's when doctors order test procedures or visits to avoid or even avoiding high-risk patients or procedures to make sure that they're reducing that exposure to liability. So there's two different types of defensive medicine. There's positive and negative. Positive is when you do more things, you order more tests, you see the patients more frequently, or you do more procedures. That's not necessarily a positive thing because it's clearly going to lead to more money for the patient and for the hospital, and it's going to lead to that patient being in the hospital longer, which can in itself lead to adverse outcomes. It leads to more treatment rather than better care, right? So you're doing more things, but it doesn't mean that patient's going to be better because of that. Whereas negative defensive medicine is the opposite. Instead of doing more things, we're doing less things. We're not seeing these high-risk patients. Maybe we're not going to use high-risk medications, even if they are potentially going to be the best for that patient. Or we're just not going to do procedures because we know that they're going to be high risk. So why do some of us do it? Well, I think a lot of you that potentially said yes, this is probably the reason why. Some of you were thinking maybe it's because the patient is seen as someone that's potentially already seeking compensation. They're out there looking for a reason for something bad to happen. Maybe it's going to reduce our anxiety of missing a condition, that assurance behavior, you can call it. And we feel that by doing all these things, it's going to safeguard ourselves. But if we do more tests, we're spending more money. Will we actually be sued less by doing that? Well, in the 1980s, if we look at anesthesiology specifically, and this was the only data I could find looking at this specifically, they had more improvements in safety through more technological advances, but there was still an increased risk for malpractice claims. So doing all these things, having these more in-depth testing, medications, what have you, didn't actually lead to less claims. It led to more claims for them. And a lot of it's for those of us who feel that we practice offensive medicine, and even those of you who said unsure, you might be practicing and not even realizing it. A lot of it's because we're just hypervigilant. Do we need to always be on guard? Well, I would say no. It's just pay attention to those areas that increase that risk. We talked about those, whether it's chest pains, these patients that have potentially meningitis, encephalitis, these high-risk infections that can lead to significant morbidity, and clearly our preventive cancer screenings. We talked about it just yesterday when we were on rounds, making sure our smokers, we're recommending low-dose lung cancer screenings, AAA screenings, et cetera. So it's making sure no matter what they come in for, doing a one-time check, because that time that they come into the hospital, I utilize that as a chance for the patient to have another set of physicians overlook everything and make sure that everything seems to be okay. So let's do another poll. So this, let me see. Okay, so why do you think patients sue their doctors? All right, so let's share the results here. We can see that the majority said it was because they're advised by someone they know, maybe a family member. The next most common was a tie between they thought that there was some cover up or they just wanted to have more information on what happened. And again, you can see that this needed information, and I agree with you, and I'm sure you have some statistics that kind of corroborate that. Is that something that we can provide them, right? It should not require a lawsuit to happen or litigation to occur for these patients to be able to get these answers. So why do patients sue? What the primary amount was they were advised, as the majority of you said, 36% said that it was because they were sued by some or advised by someone they know. And that was what we saw nationally as one of the higher amounts. Some of them, it was they just needed money. They believed there was a cover up. Some wanted to focus on the future of their children from a financial standpoint. Only 14% truly felt they needed information, and then 13% wanted revenge. So a lot of these statistics that we're seeing, and this is from the national level back in the 90s, kind of corroborate what a lot of you had answered in this poll. So what is the goal of the litigation system? Sorry, let me just put this pie chart in here so you can see that. So, corrective justice, making sure that this error that occurred is not going to happen again, securing compensation, and really just discouraging practice. The goal is really to discourage the practice of negligence, right? Making sure that, hopefully physicians know that there's a standard of care that's expected and that's going to be upheld. So the top 10 specialties for lawsuits, surgery, as we can imagine, given the high risk for it itself, was one of the highest ones. Anesthesiology, I thought was quite interesting as one of the lowest, with OBGYN and ENT, again, surgical perspectives as one of the highest. So were physicians surprised by the lawsuits? This is a survey that came out last year from WebMD and MedCalc and MedPractice. And what they found was 58% were very surprised by this lawsuit. Some 29% with some were surprised. 13, unfortunately, were not surprised at all. And then they foresaw it based on the outcome and maybe their interactions with the patients. And what ultimately happened with some of these, 2% were settled at trials. And then it was 30% were settled well before trial, whether that was from a monetary payout or maybe it was just dismissed. And then 62% said that the judge returned a verdict in their favor. And of those who have had a lawsuit, I mentioned this earlier, some said that they went to a smaller hospital, they stopped practicing medicine, or even went to a different area of medicine. 49%, I think, is a good thing, in a way, as long as there's no clear negligence that's occurring, that they made no changes, because we shouldn't, again, be hopefully practicing defensive medicine or no longer trusting their patients, as 26% ultimately said. And documentation. So I wanted to include this in here because almost all of us use Dragon. So I've seen this in multiple notes where there's this disclaimer, portions of the record have been created with voice blah, 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 recognition software. But 20% of cases that were reviewed for malpractice included some form of dictation as an error. And they found that 217 of the dictations using Dragon Medical, 44 were operative, meaning they occurred based on operator error. 83% were due to office staff error that were translating for them. 40 were occurring on discharge summaries. In the end, it actually does not decrease your risk for litigation. It increases your risk, because what you're doing is you're admitting that there's probably errors that have occurred and you have not taken the time to review them yourselves. So the thing I wanted you to take away from the slide is, do not put this phrase in your notes, because it's actually increasing your risk for litigation. If you look at some fun examples, one of them said we checked the baby Jesus instead of we checked the ABG. So this might be helpful from the ICU perspective. Patient was intubated with a kaleidoscope. Hopefully not. The patient has had a hard time breathing versus breathing. Testicles are mildly prominent. It was a brain MRI. So his ventricles are mildly prominent. So this is the time where I'm going to have to kind of cut through here. So I'm going to go to one case here. I'm going to do case 2. So you have a patient with persistent AFib on Coumadin with an INR that's at goal, and they came in for worsening abdominal pain, and they were found to have a hematoma on their CT abdomen in the ER. General surgery was consulted, but they did not feel surgical intervention was advised. And they advised and said that they just be admitted for general observation. So medicine was consulted for admission. On hospital number 3, the patient was found to have worsening abdominal pain with a drop in H&H. Surgery was notified, anticoagulation was reversed, and a CT abdomen pelvis was ordered stat because there was concern for this hematoma worsening. CT imaging was performed overnight and revealed evidence of blood extravasation into the retroperitoneum, and the findings were related to the overnight intern. The intern did not contact the resident nor the staff regarding this imaging. And the following morning, when the imaging was found by staff and the rest of the providers, they immediately notified general surgery, but by then the patient would later decompensate and pass away. So I'm going to do a quick poll here. So let me pull this up here. So who do you think, based on this case, was at fault? Was it the attending staff? Was it the general surgeon that was consulted? Was it the intern? Was it the supervising resident that was overseeing the intern, or was it no one? I guess, and there's another option for everyone. True. So let me share the results with you. And 39% of you are saying it was the intern. No one is 28%. The attending staff, 11%. So this was, let me stop sharing the results so you can see the screen here. So this is actually a case that happened to me when I was a staff attending in the military. And what we found was I was the overnight I was the attending on the case, but I was not the attending on call. I was never notified, nor was the attending that was on call notified about this. And ultimately the military did review the case to find out if standard of care was met on my end, even though I had nothing to do with the reporting of the results. And in the end, I was found to have met the standard of care, because when I came in at about 5 o'clock that morning, I immediately noticed the imaging results. And before even contacting my resident, I started getting the ball rolling on treatment. So that was kind of what protected me, was that I did not rely on the resident or even the intern to do it. But the intern in the end was actually reviewed for this case, but I can't tell you what happened with them out of protection of their privacy. So I'm going to run through this, but background on teaching residents, just know that it's important that teaching residents and fellows, they are going to be held to the standard that the attending or their specialist is functioning at. So just making sure that there is a standard of care that is expected for residents, but it's going to be at the level of the attending. So we as attendings face our own types of liability, but it's important to know that because of that, we have to make sure that the residents are documenting appropriately. So practicing does have its own risks, And interns, yes, you can be sued. So be aware of that. So I want to really spend some time right now. I have about a minute left on the 3 R's program. This is the most important thing for you guys to really get out of this talk. It stands for recognize, respond, and resolve. It's a reimbursement program that's utilized by COPIC for helping patients with expenses when there's been an adverse or unexpected outcome. So basically what happens is patients can, if you notice that there's an adverse event that happened, you can go and talk to the patient, you say sorry, you talk to COPIC about it, let them know that you're about to do this. You need to let them know before you go in and talk to the patient. And they can offer up to $30,000 of financial reimbursement to that patient, but it does not limit their ability to ultimately pursue legal options. The hope is that by offering this gesture of goodwill that they will not, but it's important for them to know that they are still able to pursue legal action if they want. But this is something that's highly recommended from not just Parkview, but from COPIC, is to utilize this. Because if we do it early, they have clear data that shows that utilizing this 3R program has been beneficial in decreasing our amounts of liability. So again, patients can receive reimbursement for not only their inpatient stay, for other out-of-pocket expenses. The results are from the results of the 3R program. Just because they get money does not lead to any documentation to the practitioner data bank as well as the medical board. And again, patients can still pursue legal action, but you cannot use this if the patient has already died, if they've already pursued legal action or gotten counsel, if there's a summons for legal action issued against you, or the state board has already intervened. So this is, again, supposed to be done very early on in hopes that it's going to decrease that risk. You have to voluntarily enroll in this program. So just because you're in COPIC as a physician here in Colorado does not mean that you're eligible to use it. You have to either call this number. If you scroll to the very top of the chat window, you will see that I've provided some links that you can watch a video webinar and then be enrolled into the program. And then once you're enrolled, you can report a case 24 hours a day, 7 days a week at this number. As of 2017, almost 1,700 physicians have actually participated and utilized this program. So that being said, does litigation improve quality of care? It's hard to prove. I would say it probably does not. A lot of us are probably practicing, whether it's positive or defensive medicine, but as I've argued, it doesn't necessarily mean that the quality of care has actually improved. And remember, only 2% of doctors are accounting for 39% of claims. So we are doing the right thing for our patients. We always have the right intentions in mind, and we're not bad just because errors occur. We never mean to do harm, but we're human. And it's okay to say sorry. I would argue say sorry early on and use that COPIC 3R program as early as you can, and utilize the power of QI projects to help decrease that systematic error. So then we know that human error is unavoidable, but that systematic error is something that we can fix. That is all I have for you. Only went 2 hours or 2 minutes over, which is probably a record for me. I will leave this open to any questions that you might have. Thank you. All right, I don't see any questions right now. I will send this PowerPoint lecture out to Jody so then she can send it out to you all, because there is a lot of information, especially on the resident attending area, that I unfortunately had to kind of go through. But I tried to put as much information as I could so that you guys could utilize this after the fact and have a good reference to go to. You're more than welcome to email me. I'm in the Outlook system. Find me in the halls. I'm the only short, Indian guy than Dr. Patel out there. So please, if you have any questions, please let us know. But otherwise, thank you for your participation.